Okay, we'll go ahead and get started. Hi, everyone. Again, my name is David Duong. I'm the director for the program in global primary care here at Harvard Medical School. Welcome to our COVID-19 webinar series, the Global Primary Healthcare Response to COVID-19 Pandemic. Today, we will kick off the third session of the series, which is the second part of the series, which is the future of primary healthcare. So in the last two parts, the last two sessions, we looked at the global primary care response to COVID-19 from around the world and what primary care practices and primary care providers were doing in response to COVID-19. For the next, for this session and the upcoming session, we'll talk about what the future of primary healthcare will look like after this second wave, this first wave of COVID-19. So thank you so much for joining me. At the bottom of your screen, you will see a Q&A icon. We ask that you use that function to ask your questions, and our panelists will type in their responses during this webinar. Our panelists will also answer some of those questions live at the end of all of the presentations. And finally, we will make sure that all of the questions are responded to after the webinar has ended, and the answers will be uploaded onto the landing page, which is where you can find recordings of previous webinars as well. If you go to www.primarycare.hms.harvard.edu. So today I'm joined by three panelists. Edward Booty, who is the CEO of Reach 52, delivering social enterprise innovations in digital primary healthcare to the Southeast Asia region. Ms. Lundi Ann from Cameroon, who is a civil society advocate and leads humanitarian programming and is also the co-lead for the health cluster for the Northwest and South of Cameroon. And then Lucas Trout, who is who oversees the social determinants of health primary health care programs for a native tribe, for the native tribes in Alaska. And finally, our discussant today will be Dr. Shannon Barkley, who is a WHO technical officer for primary healthcare. So welcome to all of our panelists and discussants. And with that, I will kick it over to my colleague, Lundi Ann, for her presentation from Cameroon. Lundi.
I think now it should be fine. Okay. Good. Thank you very much, Dave, for the introduction, and thanks to everybody who could join us today in our webinar. I am Lundi Ann, as rightly presented, and I'll be speaking about the future of primary healthcare in the COVID-19 context with insights from Cameroon. I would like to start off by saying that Cameroon recorded its very first COVID-19 case on the 30th of March 2020, and currently we are at 3,529 cases with 140 deaths. The rapid spread of COVID-19 in our communities and the impact it has had on Cameroon's health system has enabled the introduction of new strategies and new ways of delivering primary health care services. Interestingly, some primary health care facilities have rapidly integrated infection prevention control measures into their service delivery packages. And at primary health care, in most communities, the putting on of face masks has become the norm. Is compulsory now in Cameroon. We have facilities that have set up hand wash stations at the entrance of the facilities. We have within facilities primary healthcare providers struggling to put in place physical distancing measures. And of course, we've had curriculums, training curriculums for community health workers being modified to integrate components of COVID-19 prevention to encourage community sensitization. However, very many primary healthcare facilities are still heavily understaffed and under-equipped, and we have shortages of personal protective equipment. A lot of primary healthcare workers still continue offering care without any PPE at all, which exposes them to further risk of being infected as well. Very many primary healthcare workers have benefited from any trainings at all regarding infection prevention and control at primary healthcare level. And also diagnosing capacity so far has been limited to regional and central hospitals. We virtually don't have any testing capacity at primary healthcare level. Yet we forget to know that primary healthcare forms the foundation of any emergency response, as cited by Dunlop et al. 2002. So if Cameroon or any other low and middle income country has to succeed in eliminating COVID-19, strengthening primary healthcare system to offer essential healthcare should be part of its new normal. Faced with this pandemic, researchers and communities have been talking a lot about the new normal, getting to adapt to dealing with COVID-19 in the current context and even post the COVID-19 era. This is quite important because, and it requires us to be thinking a lot about how we can possibly continue, how we can possibly support the response, the COVID-19 response, while ensuring that other health care services which are much needed by the communities are not neglected. I designed this framework to illustrate how primary healthcare systems can be managed, can help in managing and in emergency preparedness, response and recovery, and also to ensure that the social determinants of health, which have been caused or have arisen because of the COVID-19 pandemic, could be addressed effectively in a bid to restore back communities socially and economically. And in this model, I recognize the importance of coordination and referrals to play a very key and important role within the different components of primary healthcare service provision. So if societies are to adopt this new normal, which I'm suggesting, there is need for strong political commitment to protect and strengthen primary healthcare services to respond to COVID-19. There is also need to promote more social cohesion and invest in community-led responses. There is need to empower community, integrate infection prevention and control measures as part of their daily lives. There is need to engage traditional and religious leaders to lead in the promotion and control measures of COVID-19 within their communities. There is need to get grassroots leaders to unite and come up with broad-based COVID-19 campaigns to make sure that at community level, the women, the children are not left out and know what to do to prevent themselves against COVID. Of course, there is need for community health workers to be capacitated to be able to contribute in the response by conducting contact tracing. Working in this new normal will require that a lot of effort is being galvanized to fight the misinformation and all the myths that surrounds COVID-19. And what better way to do this than to fight it from the community, from the grassroots. And in doing that, to be able to do that, I believe that it's very important that community leaders, traditional leaders, religious leaders, and NGOs come together and run community-based educative campaigns, because communities will definitely listen to their leaders, and then not making sure that primary health mobile clinics systematically integrate COVID-19 sensitization as part of their service delivery packages. Same goes with the humanitarian community, who also ought to integrate and develop COVID-19 campaigns in conflict-affected areas, especially in areas where a lot of people do not have access to information or do not have access to ready access to health health services. And it's quite important that these messages are translated into languages which are best understood by the community. Dealing with COVID-19 in this new normal framework, which I presented, would definitely present with some challenges. Some of which I've presented here are inadequate funding to actually strengthen primary healthcare systems in this era. And of course, limited access to internet and telecommunication services. And this is particularly true for low and middle income countries. A lot of communities do not have access to internet. A lot of communities do not have access to technology, which could be used to better provide alternative models of care. Inadequate access to or inadequate infection prevention and control measure support, especially for difficult and hard to reach communities, and limited access to personal protective equipment for frontline primary healthcare workers. The opportunities of dealing with COVID-19 in this new normal are high trust on primary healthcare facilities by the communities could be leveraged, because currently, for example, in Cameroon, a lot of people scare away from accessing tertiary and secondary hospitals because they are aware that that is where COVID-19 patients are being treated. So they'll rather go to the clinics which were not originally the first point of contact for most people in the community. So these clinics have become now the first point of contact for the communities, and we could leverage that to really provide essential healthcare services and contribute in responding to the pandemic. And also, there's been an increase in innovative models which are being developed by a lot of people. Some Cameroonians are coming up with telemedicine, which they are piloting, and these are technologies which we could exploit and scale up nationwide if possible. Also, we're looking at the integration of emergency preparedness, response, and recovery at primary healthcare level, which is quite important because most of the communities now rely and trust that they can have access to quality service at primary healthcare level without endangering themselves to COVID-19. And of course, there's a lot of capacity building going on online, which could be leveraged and to capacitate frontline primary healthcare workers, community health workers, and of course, NGO frontline staff. Thank you very much, Dave. Over to you.
Great, thank you so much, Lundi. I'm gonna go next and share the experience from Boston. So, there we go, okay. So I'm really excited. The last two sessions, I've been listening a lot, and now have the opportunity to get to share with all of you. So this is one perspective on the future of what the future of primary healthcare could look like after COVID-19 from the United States. And I just want to preference that the primary care site that I work in belongs to a very large hospital system, Mass General Brigham, and it also belongs to, or is affiliated with Harvard Medical School, where I am. So in this slide, we can see how the pandemic has really shaped primary healthcare delivery in my healthcare system. So at the beginning of March, which is the timeline is on the x-axis, we can see that most of the visits were mainly in person, which is in the blue. So these are face-to-face encounters. And then and we were averaging around 1,000 clinical encounters or 1,000 visits per day. And as the pandemic continued to grow and spread in the United States, we saw that patients became a little bit more scared of the clinic, and we saw that our numbers drop. We quickly realized that that we needed to still continue to see patients, and piloted a virtual platform starting the week of the 15th through the 19th of March. So the orange here is the virtual visits. And as you can see, on the 23rd of March, the Massachusetts governor ordered the shelter in place So that was basically our equivalent of a lockdown. And almost immediately, we can see that this transition, which took almost a week to go from mostly face-to-face encounters to over 90% virtual encounters. So this virtual encounter here means from the telephone or from video encounters, with some face-to-face encounters in the blue, as you can see here. And we've been able to quickly ramp up our virtual encounters, and not to the level that we were before the pandemic, but almost there. So like I said, these virtual encounters included a very quickly, it was integrated into our electronic health record and our patient management system. And we were able to quickly put in this video icon right here, where we could see the patient's name and the type of visit and who their provider was. And then this video column quickly showed up here that we can just click on. And once we clicked on that, then it would pop up, and the physician, and then the patient, and we would be able to have our clinical encounter with the patient, and this is via the Zoom platform. If the patient didn't have this software already on their computer, or if they didn't have a computer, we could always go to a regular phone encounter, and with a free application called the Doximity application that most of our phone, or a lot of our phone encounters are through, we can easily switch the phone encounter over to a video encounter in the app without the patient having to download any software, if the patient has a smartphone and has a webcam. If not, then we would just continue the encounter via the phone feature. So I talked about that there was still, even though we were doing a lot of virtual visits, there were still some in-person visits, because we noticed and we realized that quickly that there needed to still be in-person visits in order to do a physical examination, to get vital signs, to get labs. So our clinic quickly, very rapidly devised up 2 protocols to triage patients at the time that they called the clinic with their complaint, or when they or for appointments. So in this graph, in this schematic over here, what we see is for patients that have a non-respiratory complaint. So immediately patients are kind of separated between respiratory complaints and non-respiratory complaints. And if a patient had a non-respiratory complaint, they would call our clinic like they would normally, and a nurse would triage them, and the nurse would then see if hand them, after the triage, will then schedule them to have a virtual visit with a provider, and the provider would then make the determination, can they handle this with a virtual visit, or does the patient need to go and be seen in person? If the patient needs to be going and seen in person, the provider triages them again with a COVID-19 screening form, and if the form is negative, they get to go be seen in the non-COVID clinic or the non-respiratory clinic, and if it screens positive, then they are triaged to a separate respiratory clinic. We also very quickly developed a triage protocol for patients who had a respiratory complaint, and they could either call the clinic as they normally do, or they could call a hotline that was set up for respiratory complaints. And again, the nurse triages the patient over the phone, sends them to a provider, and then the provider then talks to the patient via a virtual visit, and then goes and refers them either to the virtual respiratory clinic, or they are treated at home via the phone or via a video visit. So these systems were very quickly put into place in order to address both the safety of the patient, but also the safety of other patients that that patients could be exposed to, and then of course the safety of the staff. So now we really need, now as we are kind of winding down on the first initial wave of the COVID-19 pandemic, we really want to be looking at what does the future of primary healthcare look like? And we know that we're utilizing virtual visits, so they're not going to go away anytime soon. So there's definitely going to be an increase in virtual visits. There's also going to be an increase in enhancing the use of mobile clinics or home-based care. We are already seeing this a lot already with the pediatric population and mobile vans going around and doing immunizations, vaccinations, well child visits, etc. So really increasing the use of delivering care directly to people either at their home or in the community. And then, of course, we're not going to get rid of completely the idea of in-person visits. So thinking about what that means, and if we're going to have to set up two types of clinics, one for respiratory complaints and one for non-respiratory complaints, or sections in the clinic at least, in order to keep other patients and staff safe. So I want to talk now about creating this idea of creating resiliency in primary healthcare to make sure that our primary healthcare system continues to evolve and continues to keep our communities safe and our economies open. And in order for us to do that, we need to look at primary care as a key strategy to the COVID-19 control efforts. As we ramp up community testing, as we ramp up the ability to screen community members and patients, and also once if a vaccine is going to be developed, it's going to have to be deployed and delivered. And primary healthcare really needs to be a key strategy in all of those areas. We need to change how primary care payments are made. So in my system in the United States, primary care payment is usually made with encounters. So I see a patient and then I bill the insurance for it. And that's physically see the patient. During COVID, we have had Medicare and Medicaid reimburse for virtual visits. However, these virtual visits are only reimbursed at almost about half the rate of which in-person visits are reimbursed at. And primary care practices were already struggling prior to COVID to make sure that they were seeing enough volume for reimbursement. And now if we're only able to be paid half of that, but have to see the same volume, we'll have to see more volume. So because of that, a lot of talk has been given around this idea of bundled payments or global payments where insurance companies will give primary care practices a set amount per patient per month or per year. And the idea is then that it's between the patient and the primary care provider how to best deliver their care. So it might be some in-person visits, some virtual visits, some home-based visits, etc. And we really need to think about how to change these payment mechanisms because that's going to be a key strategy. We need to integrate and adapt technology. We're already my primary care system did that within a matter of weeks, and that was thought to be impossible before. But this is a really big black box and an opportunity for innovation and for private sector to come through and really think about how do we link the information that's already being captured by smartphones, such as heart rate, such as walks per day, like how many steps per day, and into a portal that then primary care providers can see this objective data. Can we envision or imagine a day when a patient can take their blood pressure at home and that blood pressure and their weight, etc., can then be fed into the phone, which then is fed to the primary healthcare provider. And these are things that seemed almost impossible before, but I think that with our rapid integration and adaptation of technology, this may not be so impossible in the future. I won't talk much about addressing the social determinants of health because the next talk is going to really discuss that, but primary care needs to play a bigger role in that. We need to ensure that our primary care response is prepared for future surges and also future health threats. So for us, this means there is going to be an onset of more substance abuse disorders or more mental illness disorders. Are primary care clinics ready for that? And are we ready to deliver that type of care virtually and also in person? And also we have to think about surges of COVID again with other seasonal threats such as flu. And then, of course, lastly, the adaptation of new models of patient care delivery. So thinking about the virtual models of care delivery, the in-home, in-person models of care delivery, what types of care gets to be delivered, what types of services get to be delivered by what mediums. These are all still big question marks that we have that we need to address. But the silver lining here is that these were all questions that we had for primary healthcare that existed before COVID. But I think that what COVID did is it pushed us to really think about these questions and these issues much faster. And we could imagine where we would end up with actually a better primary healthcare system than we did before. And if we can imagine a primary healthcare system after COVID that actually ends up saving money, being more effective, and increasing patient convenience and satisfaction. So I'll just end with this slide. This is a slide of Hurricane Gloria, which hit the eastern seaboard of the the northeast seaboard of the United States in the 1980s, and it left a lot of destruction. Hurricane activation system, so the better come. The first dangerous wind of COVID and turn it into an opportunity to really enhance the primary healthcare system. And then the second is never this crisis. So what I mean by Lucas. Thank you.
Go ahead and share. So I'm speaking from the polar up above to the primary healthcare region across patients, all 100,000 of whom are rural or remote, which in the Alaska context means no roads connecting the villages to each other or to the outside world. Served by small clinics to each other. From where I work in this region. So the system lives system actually when tuberculosis swept through northern, really decimated communities. So initially the public health response at the time was centered on moving infected patients to care centers as far away as Seattle, which is about 2,000 miles away, which was experienced as a policy of forced displacement by a lot of community members, and there was a lot of resistance to this practice, what essentially amounted to going away to die amongst tuberculosis by local model. Health workers partnered with traveling public health nurses to administer a directly observed therapy program, which was very successful. community health aid front lines of rural Alaska primary. About 250,000 annual clinical encounters over 180 remote village sites. So the model partners community health aides, CHAPs, with traditional providers at regional hub hospitals via telemedicine. They gave us the communities. So the infrastructure was in place to very quickly move to a more or less exclusively telemedicine-based primary care system. So I think it's important to understand as a backdrop to the pandemic that Alaska Natives have long held a state-conferred right to health as a result of treaties and a trust relationship with the United States government. And that this right, of course, applies to the tremendous challenge we're going to be facing in Alaska over the coming months and years with respect to COVID. It's also important to understand in the American context, which is already broadly characterized by a profound degree of social inequality, that American Indians and Alaska Natives have historically been uniquely marginalized by government policies that undermine health, social, and economic rights. Still, Alaska Natives have a federal and tribal administered health system free to beneficiaries that's drastically improved life expectancy and a range of health outcomes over the last several decades. So my work in the Alaska tribal health system is centered on bringing a social medicine lens to primary health care to address the underlying social causes of disease and to understand and deliver health care around this understanding of health and illness is fundamentally social. So what we do is a combination of very nuts and bolts work to address housing and food insecurity, safety, mental health, cultural wellness through our region's primary care system, but also larger scale projects to strengthen primary healthcare across Alaska, to respond to community development priorities, to conduct health research and advocate for sound American Indian health policy on state and federal levels. So in primary care clinics themselves, what this looks like is teams of social workers, doctors, nurses, and community health aides that work together to deliver comprehensive care for the social determinants of health alongside the sort of more traditional purview of clinical medicine. And COVID-19 is a really strange disease on this front because we have a single active confirmed case in this gigantic service area. Being as remote as we are, it's been very slow to come to the region, and the tribes have the authority to exercise local option laws that further restrict travel and enforce quarantine beyond the regulations put in place by our state or federal government. So we've been able to keep COVID out of the region for a fairly long time, with the first case confirmed just the day before yesterday. But what this means is that that COVID is for us to this point essentially a function of the unintended consequences of these measures to prevent it coming to the region and prevent its spread once it does. So it's had pretty massive social and economic fallout in spite of very little direct health impact from the disease itself. So over the past couple months, we fortunately had a lot of time to think about how we were going to respond and develop an operational framework for a social medicine response to COVID-19, which in the right-hand column, you can see some of the particular aspects of our region's response in Northwest Alaska that are grounded in social medicine and have involved this coordination of health, social, and tribal government services that's really at the heart of our model. So the broader point I'd really like to make is that COVID-19 is a social disease and will require a social medicine response wherever it lands in my health system across the United States and globally. And by that, I mean that illness, exposure, care, and outcomes are all stratified along very familiar social, economic, and racial lines wherever COVID-19 takes hold. I think COVID really lays bare the social structures that always drive health disparities. My big concern here is that the pandemic is going to further entrench those social inequalities. The positive alternative for the future of primary healthcare proposed by social medicine is to shape a response to the pandemic and to our approach to healthcare generally that redresses these inequalities as a part of our approach to mitigating the spread of the disease and to primary care delivery generally. So in Alaska, the most straightforward aspect of our COVID response really has been the narrowly clinical dimension of adapting our existing telemedicine infrastructure to handle the vast majority of primary healthcare visits. So traditionally, we have community health aides facilitating telemedicine sessions with traditional physicians or APCs at regional hub hospitals who can perform basic procedures, examinations, can auscultate and communicate with that provider. And we have since moved over to largely direct-to-consumer phone-based telemedicine with clinic visits for some issues that require that hands-on touch. And so that system has been phenomenal and has been further supported by clinical fellows in Boston who are ready to staff our radio room and primary care clinics, as well as academic partnerships with David's health system that have allowed us to adapt best practices for emergency response and crisis standard of care, as well as on my own social medicine team, teams of social workers, therapists, community health workers, and psychiatrists who are working to address the unintended consequences, largely psychosocial, of quarantine, rising unemployment, limited access to food, and the profound stress that has come along with the pandemic. All that said, I think the highest yield interventions are almost certainly going to be those led by the tribes directly, who have exercised their authority to institute travel restrictions and quarantine policies that exceed state mandates to protect very high-risk communities that also already face large health disparities, as well as limited health infrastructure to address an outbreak should one eventually come. So in that light, the Regional Native Corporation very quickly issued emergency shareholder dividends to defray the economic impact. So essentially immediate cash disbursements to tribal members, and provided funding for a hardship mitigation program to ensure food security because we've had significant supply chain disruptions. Finally, we had a traditional foods program that supported subsistence hunters donating caribou and other foods to elders and families in need. And I say all of this to illustrate the sorts of things that I think count as primary healthcare during this time and really always should. If we're to accept this premise that the vast majority of health determinants are social in nature on one level or another, then I think we really need to broaden this definition of primary healthcare during COVID and beyond. So this sort of brings us to the future of primary care in the coming months and years. I don't know that any of us knows how long this is going to last, but my hope is that we'll finally take to heart this idea that there's really no meaningful differentiation or way to divorce care pathways for the social, economic, and biologic drivers of illness. And then we start thinking about a level of horizontal integration of government, health, and social services that the Alaska Tribal Health System is already accomplishing moderately well. And I have full faith will do better and better over the course of this pandemic by necessity alone. So my hope is that we reconsider what counts as primary health care. We reconsider who delivers it, and we start to include things like family caregiving, public health, and social medicine as part of the essential purview of clinical medicine. My hope in the US context, in the absence of strong central federal leadership, is that we learn 1,000 small lessons from the necessary care innovations of local communities and most of all, that we take advantage of the unprecedented levels of political pressure and commitment to global health as a moment to draw attention to the fact that all medicine really is social medicine, and that we start building primary care systems as if this were true now and always has been and always will be. So I think I'll wrap up there. I appreciate the opportunity to share a little context from Alaska, and happy to answer any questions at the end.
Thank you so much, Lucas, for that really inspiring presentation. And next, I'll hand it over to my colleague from Singapore right now, who's based in Singapore, Edward Booty. Edward?
Good afternoon. Are you hearing me properly? Just to check quickly. Excellent. So I'll just share my screen. Good morning, good evening, good afternoon, everybody, wherever you are in the world. So yes, I'm Edward Booty, CEO of Reach 52, based out of Singapore, as David said, and we focus on last mile healthcare delivery. So we're a social enterprise operating in the Philippines, Cambodia, and India. Really, building solutions and using technology to enable healthcare in low and middle income communities, specifically rural, disconnected communities. And I guess just first comment, it's been somewhat refreshing and somewhat alarming in a way to hear the previous presentations from Lundy and Lucas, and they just all felt so familiar that I think just galvanized how much this is a global problem, and regardless of which part of the world you're sitting in, yes, COVID is something that affects us all, then it really does come down to affecting the poor the most, which is what I'm going to talk about today. So hopefully you can see my screen. So yeah, just to sort of start off with who we are and sort of our place in the health ecosystem. Reach 52, we're all about building technology-driven solutions to help the 52% of the world, or 3.7 billion people, that lack access to essential healthcare services. We've really tried to embrace a sort of decentralized model by sort of building technology that allows women or individual people in communities to provide health support beyond the health center, so going out of primary care to provide actual health support in the last mile. And we currently do that in around 400 communities in Southeast Asia. This is, as I say, very much digitally enabled, and we're really about building linkages between the healthcare providers, looking to engage about 100 million people, or so, sorry, 1 million people this year across all of our channels. And as well as using technology and training people in communities to extend government services, we very actively look to engage private sector, supplementing the available public sector services with affordable, discounted private sector services that we deliver as well, and currently offer around 500 or so products through our marketplace that fills the gaps in public sector healthcare delivery. So just a bit of positioning on who we are and how we operate within the health system there. So yeah, just sort of moving on to where we are now. And again, I'm coming from living in Singapore, but very much speaking on behalf of or about rural Southeast Asia. And I guess I'd summarize it as our headline there. There's a lot of uncertainty. COVID-19 has consumed everything within the health services, and changes are happening, but in my view, they're happening far, far too slowly. And when I was doing these slides, I did think about the 4 challenges, and I think you can sort, in my view at least, you can summarize it as these. There's low to no screening, there's very limited resources for public health, and we're now being punished for low digitization. For example, the paper-based systems or the lack of digital means that we can't pinpoint services or rapidly deploy essential interventions or essential information into more rural, remote populations. Additionally, the decisions are quite unpredictable. We do a lot of work in the Philippines, in Manila. The lockdown was quick, it happened out of nowhere. You know, you're not really sure if it's going to be extended or not. And as has been referenced by the previous 2 speakers, there is this broader economic impact to juggle as well. The role of day wage labor, people aren't going to call in sick, you know, if they do have symptoms, because they have to work to get paid, which obviously increases the spread risk. And on the flip side, people do need to keep the economies going. They don't have big budgets like Europe or the West or Singapore to shut the economy down for a long period of time. Additionally, there is just a huge limited focus on wider healthcare issues. So by focusing on COVID, we're already seeing non-communicable diseases or vaccines or maternal health services be cut due to supply chain issues or whatever it might be. And I guess on a more positive note, there is really some movement in some of the quite prohibitive regulation. So for example, in the Philippines, telehealth and e-prescriptions were completely banned up until 3 weeks or so ago. But now we can do telehealth, and virtual doctor consults are legal, where they haven't been for the last 4 years or so since I've been working in the Philippines. So we are seeing some positive change to David's point as well. And just to put some data around that, and this isn't in any particular order, but post-SARS, the mass testing approach isn't there. Within the Philippines, 0.1% of people are going to be tested. The government has come out this week and said they're not leading it. It's going to be completely left to private sector, and it's a private sector enterprise, which is worrying. The infection rate, 16% of all the infections in the Philippines are the health workers themselves. That's against an average for the Western Pacific, which is the World Health Organization region that covers us, of 2 to 3%. So a lack of PPE, a lack of planning, a lack of resources. It's often the health workers paying the price for that. University of the Philippines came out to, just with the current growth of COVID or the expected anticipated demand, they're 35,000 hospital beds short. There's one government doctor per 33,000 residents, when the World Health Organization recommends 1 to every 1,000. And 50% of planning services have been cut. That's just a stat that I found so I could evidence it at the bottom. But even sort of anecdotally from our service, we took some orders for diabetes medicine, we couldn't fulfill them. That supply chain isn't there. So we're really starting to feel the impact of vaccines being missed, or family planning not being available, which is certainly going to have an impact far, far beyond COVID. As Lucas said, COVID might never get to these communities, but they might well die of something else, which is very unfortunate, of course. So just sort of taking that, and thinking about our model, as I say, we do build digital systems, we do deliver primary healthcare throughout various countries in the region. And I think the role of digital and how we embrace digital and how it can support, I've broken apart into 3 categories. One is that digital obviously just provides the ability for reach and scale, and helping reach populations beyond brick and mortar. For example, just to sort of try and put some data behind all of this, we've been running, we built a Facebook chatbot to get COVID information, do symptom checking. We're reaching patients for less than 2 cents of ad spend. So we're promoting via Facebook ads. That's reaching 50 people for every $1 we spend approximately. So really giving big reach. We're currently scaling that up to reach about 1 million people in partnership with one of the biggest pharmaceutical companies in the world. And then when we connect people and when we build this channel, it really does start to mean education for all, which is fantastic. As again, as Lucas said, the social determinants of health we should break down these barriers now. And if we allow them to perpetuate, it's shocking. It's an ethical problem as well as a public health risk. So by providing education for all, is essential for prevention and also anything else to do with any disease. And again, our chatbot, 6,000 users in the first week with very, very little promotion. We've now put that in 15 languages, looking to support 10 countries in Africa with the tech we've built, as well as other countries in Southeast Asia. And then again, as a result of this rapid digitization, I hope it leads to more data, less paper, better transparency, more accountability, and sort of allowing that long-awaited shift to sort of digital health systems that is very badly needed. And as mentioned earlier, the government's recently permitted e-prescriptions and telehealth in the Philippines that we've wished for many, many years since I've been working there. And then sort of going beyond this sort of immediate support, how can digital enable recovery, and how can it get economies back on track? Firstly, I think it allows, given that different regions are going to have different needs, it will allow for different subnational policy. So Manila might be shut, but other cities or other areas might be allowed to operate. And given that some areas are less economically developed as others, this will allow for a gradual reopening of the economy. And we're already seeing this, for example, in India, where the states vary the rules and they allow different states to operate differently based on the prevalence of COVID. Additionally, we should end up with a stronger workforce. So by investing in health workers now and by connecting health workers and being proactive and valuing them and hopefully paying them more, this is good. And we are currently sort of training and looking to reach around 2,500 health workers with training plans. And again, that's just our effort, but across the entire spectrum, really improving healthcare workers is good for primary healthcare, for universal health coverage and other global goals. And then once you've done that, I think it's a great platform to scale. So we can support all diseases, right? If we strengthen primary care, if we invest in the health workers, if we build digital channels, if we build data, that can support all diseases through new, more efficient, better trained channels. And again, I try and put things in numbers from our point of view, but at the start of this year, we were trying to get 200 medicines in our marketplace to offer the communities that we work with, so discounted private sector products. And I'll be very open that I had no idea how we were going to hit that number. And me and a couple of the team sort of set this ambitious goal of 200 medicines that we were hoping to get from private sector to support our work. We've already got 500 that have been offered, which sort of shows that people are willing to participate now. And we're in discussions with about 1,500 more in Cambodia in the Philippines, which sort of just shows that there's this private sector willingness to engage and this ability to go beyond into other areas and other diseases and really look to achieve the sort of UHC or Sustainable Development Goals with the sort of 10-year countdown upon us now. So overall, I'm optimistic and I am hugely excited, I guess, about the leapfrog or the transformation that can take place as a result of COVID to really try and bring essential healthcare services to millions upon millions of people. But that said, when we think about the blockers to making this permanent, I think I break it down into three. One is the regulation standardized. So the rules in Manila, 14 million person city, say around going to a pharmacist, makes sense. Pharmacists should be legal. Or keeping medicines at 25 degrees, makes sense. It doesn't work in rural areas, right? You can be 4 hours from a pharmacy, it can be 35 degrees with no aircon. So digital is great, but it's also dependent upon a functional system or a broader health system, pharmacies, clinics, and so on. So how does the regulation vary is essential. And how do you sort of also allow innovation, but without creating silos? So often, huge boom in digital innovation, huge boom in telehealth, lots of apps popping up. They're all proprietary. They're all going to have their own databases. And as we've seen in the UK and many health systems, this can be hugely difficult to maintain in future and sort of create a trap that, means that data can't be shared across multiple providers. And there's just difficulty in accessing and maintaining a comprehensive health system. And then beyond that, as much as health workers are sort of the focus at the moment for many different ways, the numbers are just still too low, right? I'll go back to the initial statistic that there's one government doctor for 33,000 Filipinos and the recommendation is 1 to 1,000. We just have to spend more on health and we have to have more health workers. And even if there is 1 million more health workers in the Philippines today, they're not going to perfectly distribute across the rural areas. So the need to improve the number of health workers and grow it, but also embrace innovation to allow it to reach the more marginalized communities is absolutely essential. And then I think my final point on the blockers is really thinking about how the vested interests of certain groups or certain companies will have an impact. So yeah, we really do need to realize that by pushing innovation and by pushing e-pharmacies or whatever it might be, some people might lose out, and sometimes those issues are very entrenched, and therefore we need to be careful and aware that pushing innovation means somebody's going to lose out, and that's something the government's going to have to address upfront in low and middle income countries. So with that, I will stop sharing and thank you for the time.
Great, thank you so much, Ed, for that perspective. And now I want to hand it over to my colleague, Dr. Shannon Barclay from the World Health Organization to help us kind of put all these presentations together and give us your insights as well. Thank you.
Thanks, David. And thanks to all of you for joining and for the work that you're all doing on the front lines around the world, both to our panelists and to those of us who are joining as participants. I also want to thank the panelists who, for making my task here extremely difficult. I think adding value to those exceptional presentations from numerous contexts is going to be really challenging. But I'll just highlight a few points that I will focus on the future of primary healthcare and how we can take these lessons from the response phase into early recovery and hopefully on to transformation and really allow the new innovation that has been beneficial to driving social change, to driving change in our health systems, to driving change in our service delivery models, to really take hold and take root in order to be something that's sustained into the future. I think healthcare in general is one that is far too often static and in recent years has been far behind waves of both social and technological change. And I think right now we are seeing a space in which there is decreased regulation, which will be both good and bad, but that is allowing innovation and transformation and also bringing attention and renewed interest from stakeholders and communities in sectors outside of health that before sort of saw health as a dinosaur and not something that they really wanted to invest in. And I think making sure that we leverage that increased attention and renewed interest is going to be really critical. I think we've heard in terms of conceptualization of primary healthcare that it varies really broadly. In some countries around the world, it really focuses more narrowly on the clinical services and sometimes their connection to the community. Sometimes it's really broad clinical services. And then sometimes it goes really wide and talks about how those clinical services engage with the communities themselves, how they interface with social change, how they interface with community empowerment, and then also multi-sectoral action. And I think using this time, particularly when the linkages between public health, when linkages between communities and health services, when the linkages between other sectors and health have become brought into relief, is going to be really essential that we draw those linkages together and leverage those into the future. I'm going to break my future comments into just three main areas. I think we've seen some immediate clinical aspects that have changed. We've seen changes in patient flow, in use of telemedicine, mHealth, and that all of those are going to last into the future. And we're going to have to be careful to ensure that we don't sacrifice people-centeredness and relationship in that process. I think primary care services and primary healthcare at its root is about relationships and about communities, and ensuring that that is maintained through platforms that we know sometimes can be depersonalizing is going to be really essential. I think, as Lucas pointed out, we've seen brought to the forefront the importance of informal carers and home care, as 75 to 85% of cases of COVID are managed outside of the hospital, sometimes with contacts with the formal health sector, but often just managed at home by family members and caregivers who are responsible for care around the year in all settings, but we often don't give them credit for that. And so really drawing the support that those carers need to do their jobs effectively to the forefront and seeing them as an integral part of primary healthcare is going to be really essential. Likewise, the linkages to public health functions, I think prevention and promotion at the forefront, communication of risk, communication of ways to protect the community, as well as surveillance functions of primary care are going to be increasingly important. And I think we've also seen, there have been studies historically that show that in some contexts, it can take up to 15 years for new guidelines to permeate clinical settings. And we've seen technology enable an urgency-enabled uptake of guidelines and training at rates that we have not seen in recent years in health. And so taking the lessons that we have seen now to apply that same urgency and uptake of new guidelines when they have the same potential benefit in terms of lives saved and reduced morbidity is going to be really critical, and making sure that the same mechanisms and information networks that have been established are able to be leveraged for guideline uptake is going to be really important. I think the linkages between primary care and care for special populations, particularly those who are in vulnerable groups, and in this pandemic in particular, we've seen those in aging populations and long-term care facilities in particular, and primary care, how it's delivered in those settings. I think we'll also need to continue to transform through some of the innovations that we've seen. I think we've also seen some changes in the intangibles, in things like renewed trust in primary care, as Lindy pointed out, in reinstating its role in first access, as people are perhaps more hesitant than they would have been historically to jump and go to secondary or tertiary levels of care preferentially because of the fear. And I think ensuring that we leverage that renewed trust to build these relationships is going to be really critical. I think at a system level, we've seen the importance of engaging and empowering communities, not only for self-care, but also to be able to battle all the misinformation that is out there, and the role of primary care in helping steer patients to trusted resources and reliable information about what to do. Health and social service linkages, the importance of making sure that the actions that we take in health are not in isolation and to the detriment of people's broader well-being in terms of economic well-being, and really leveraging that in as a whole picture in terms of how humans thrive. And lastly, I think, moving forward, we're going to see changes in the structure. I think governance and regulatory environment changes, as Edward really nicely pointed out. We're going to see increased adaptability and flexibility, but we have to bring along the peacetime governance that is going to allow some of these innovations to stick. I think we don't know what will stick. People's expectations, people's habits, people's experience, is slower to change as we return to normal. And it will be interesting as we process this change management, how the actors within the health system will be able to embed and really hold strong to the pieces that evidence supports as positive reforms. And I think, as always, ensuring that people stay at the center of this and that we are continuing to understand people's expectations, experiences, and then adapt that to local solutions is really critical. So implementation research, improvement cycles, and never forget that primary healthcare is a specialization, and that in a space where lots of new actors are going to be jumping in, we will need experts like all of you at the front lines guiding this with evidence and research and knowledge of what works. So stay engaged. Thanks for the opportunity to comment.
Great, thank you so much, Shannon. And I'm just realizing we are at time. So there was a lot of wonderful question and answer that I think everything has been addressed already. So we will post the question and answer document online along with the webinar recording. And thank you for all of you for joining us. And also thank you to the lively conversation going on the Facebook stream live site right now as well. So with that, we look forward to seeing you at the next webinar. And thank you so much for joining today. Have a good day.